I'm Mabel Jong. Thanks for watching. I'm here now with Dr. Douglas Allen, who is Chief Medical Officer over at Optum Health. Collaborative care now you do a lot of work with the accountable care organizations and how they work and function. And I wanted to talk specifically about chronic care and how that fits into play there. Is there a special things you need to consider when you're looking at chronic care?
Yeah, absolutely. It depends on whether your ACO is a senior-focused or a commercial-focused ACO, because in the senior population, they have a higher incidence of chronic disease and frailty and end of life. It's more of an issue there. But just sticking with the seniors predominantly, any ACO will have to have competencies with regards to finding the patients, with regards to once you found them, what are you going to do with them, and then to measure the success on an iterative basis for whatever program that you put in place, and then make minor corrections over time. And so the finding part is a little more difficult in the ACO world. So just to ground, the ACO is basically some kind of a structure on top of a fee-for-service patient environment. And so it's a very open network, open-ended, not a lot of controls, no notification requirements, et cetera. So it's a little more difficult to find the patients than it would be if you're in a tight managed care setting or something like that.
Give me an example, for instance, on what you're referring to specifically.
Sure. So in a closed system that's more tightly managed, let's say you might have hospitalists, physicians
Yes.
that see patients in the hospital when they're ill for that population of patients. So when you have that kind of an environment, the hospitalist can see the patient and immediately identify them as being in need of further care, and can refer them into a program that you've developed that can help them out. Whereas in an open-ended fee-for-service environment, a patient can go to one hospital one day, another hospital for the next admission, go to physicians who don't know anything about the ACO or its existence, would never know there's a program there to refer to, and so certainly would not be a referral source.
Okay.
Would be example. The other way to find chronically ill patients is through claims. In a tightly managed system, you're paying the claims. You get the claim information immediately, so you can identify somebody as a congestive heart failure patient that has just been admitted to the hospital, and you have a program all ready for them. Whereas in an ACO world, someone else is paying the claims generally. They will feed you the claims in a much later period of time. The claims will be a little dirtier, a little harder to integrate into your systems. And so you're very late to go and try to help that patient.
So what's the solution there?
You have workarounds, and we partner with an IPA right now, Monarch, for instance. I'm in on their operations committees as they're trying to find ways to work around this by putting sleeves over their Medicare card that notifies anybody they contact to please also notify us if you could. You know, it's a very much.
And do they?
It's early days. They're getting some adoption. Is this going to be the critical tactic, or is it going to be the totality of all tactics they're using to try to work around those limitations? I don't know, but it's an ongoing challenge.
Okay, so what's the ideal picture here then of what should happen?
Well, you can continue to try to overcome these challenges in very innovative ways, and hope that reaches out to enough patients, and you find the patients in need that you're successful. Ideally, maybe over in the future iterations of ACOs, they might take more of the HMO attributes. I don't mean, HMO kind of has a bad connotation in the old days of inappropriate denials of services and lack of checks and balances and fewer patient rights, and I think those days are gone, so I don't mean that kind of old HMO style. But HMO attributes would be a more integrated population approach from healthcare information technology that can take the data and find the patients that are about to be ill and predict that they will be ill, feed those to the clinicians through the point of care, profile the physicians, incentivize physicians. So that attribute, the attribute of just healthcare information technology being brought to bear in a more rigorous way, which is more of an HMO-like attribute and something we didn't have 10 years ago. More of a restricted network, just taking physicians and hospitals that are higher quality and more cost effective, and have more patients in their panel or see more of your patients so that they change their workflow to accommodate the ACO. So that's more of something that might be considered in future iterations of ACOs. But for now, it's taking the ACOs as they come and trying to overcome those challenges. And then once you've identified them, then there's what you're going to do. And there can be an intensive program, like clinicians going to the home, 24-hour nurse line, putting biotelemetry and devices in the home, So it's very intense, very expensive, tougher to get a return on investment for that.
Right.
There's very light mailings to patients and that type of thing, and those are generally less impactful. So trying to find the balance and maybe segregating your patient populations into the more intense and the less intense based on their illness, and then measuring as you go and making mid-course corrections. So that, even though it sounds very straightforward on how to manage chronically ill, what I just said is very difficult, especially given the ACO limitations.
Okay. All right. Is there anything that I've missed that you wanted to cover on that, Dr. Allen?
On the chronic care? No, I think that's at a high level. You can go into as much detail, obviously, as you'd want to.
Okay. Well, Dr. Allen, thanks for stopping by today.
You betcha.
We really appreciate it.
Thanks for having me.
Thank you. I'm Mabel Jong. Thanks for watching.